So is the screen visible?
Yeah, it's visible.
Yes, sir.
Right. Dr. Onkar, can you kindly read this one slowly so that everyone understands?
Yes. 36-year-old old male underwent a resection and anastomosis following strangulated inguinal hernia. Post-op, patient had wound infection that was managed conservatively and healed during hospital stay. Discharged on POD7. Patient comes for follow-up after 15 days with discharge from the wound site and history of attacks of fever. How will you proceed?
Okay. Right now. So if you have this as a scenario, doctor, I think that more or less everyone has seen the scenario and now you are good to go with the scenario. Now, an enterocutaneous fistula is a very common scenario, particularly for a postgraduate surgical exit examination. Be it an MS or a DNB, even sometimes a reference examinations are always asked about this question. Okay, now to start with, understand the flow that the examiner is going to gradually take. Now, number one, Minan, can you keep the scenario on, please?
Yes, sir. I just, there's some small problem. I'll just share it, sir, once more.
Okay. Because there will be some people joining in for the next couple of minutes.
Yes, sir. I am just sharing.
Right. Okay. So, Dr. Onkar, now, so you have the scenario in front of you. Okay. So, when you have the scenario in front of you, what is important for everyone to understand is that number one is that the patient has presented with an emergency surgery and that required a part of the bowel to be taken out and also an anastomosis was done. Number two is that there has been a wound infection and the patient now came after 15 days since the surgery with a wound site discharge and a history of attacks of fever. Now, let us, without thinking about enterocutaneous fistulas, now tell me what are the clinical possibilities that come to your mind when you see the patient at the 15th day? Forget about an enterocutaneous fistula. We'll come to that later on.
Yes.
Yeah.
There could be this intra-abdominal abscess.
Okay. Any other possibilities, doctor?
Sir, there could be there could be the fistula formation.
Okay. Beyond the fistula, anything more that catches your attention? Beyond the fistula, is there anything more that catches your attention?
There could be surgical site infections.
Surgical site infection. Good enough. So if you're thinking about a surgical site infection, doctor, that's great. Because what we are now going to learn about is that on the 15th post-operative day, as you very, very rightly mentioned about it, okay, so what comes as a part of the scenario that has been described is, so you have described very effectively that the patient has come with this kind of fever with surgical site infection. Now, so what are the points that are going to make you say that the patient is going to have an enterocutaneous fistula? Because there is only one thing in the history that tells you. Okay, so what are the points on history and what are the points on examination that is going to tell you that the patient has an enterocutaneous fistula?
Yes. There will be there could be the history of fever. There could be the discharge from the wound site. There could be fecal discharge from the wound site. Associated pain. Pain which could be the out of proportion according to the post-op day.
Right. Now, very good points made. So the first suspicion of an enterocutaneous fistula usually begins after a wound infection, refuses to heal, So if you're asked questions about this in examination, that what are the points in examination that tell you that you are probably dealing with an enterocutaneous fistula. So to begin with, you are always asked about the wound infection which refuses to heal, number one. Number two, couple of days down after the wound infection has occurred and there is a feculent discharge or a bilious discharge from the wound is a second point. Number three, usually isolation of gram-negative and anaerobic organisms from the wound are thus usual indicators that you are dealing with a fecal fistula. Okay, so definitely the most obvious signs is presence of a feculent or a bilious material or a bilious output through the wound is going to produce a point about a fecal fistula. Good. Now, so let us presume that the patient underwent a surgery, and let us presume that the patient underwent a midline laparotomy for a fecal fistula, and now you have a midline wound which is draining around feculent material which is found to be around 100 to 200 ml per day. So this is the usual quantification that you are going to get in an examination. Now, doctor, so once we have the diagnosis, how do you define an enterocutaneous fistula?
Yes. It is an abnormal communication between skin and the intestinal between
Okay, so let us
intestine.
come back to the basics very quickly, doctor. How do you define a fistula to start with? When we talk about enterocutaneous,
Yes, fistula. It is an abnormal communication between two epithelialized surface.
excellent. Okay, and the fistula tract, remember, this is the important part of the definition, is lined by and
Epithelium or
tissue or remember lined either by granulation tissue or an epithelium. Now, the next part is, so how do you define an enterocutaneous fistula?
It is an abnormal communication between the epithelialized skin surface and the bowel, epithelialized bowel segment.
Excellent. So this is the first part, so that you have known. Right. Now, in this patient, the next question will be, why did the enterocutaneous fistula happen in this patient?
Sir, there could be underlying intra-abdominal collection or abscess which could lead to the development of enterocutaneous fistulas.
I could not understand. Can you repeat it once again?
There could be underlying intra-abdominal abscess or intra-abdominal collection which could lead to the development of enterocutaneous fistula.
Okay, or in a better way, we can say that, sir, enterocutaneous fistulas form either because of an iatrogenic bowel injury,
Yes.
or number two, an anastomotic leak, again an iatrogenic cause, in or with or without the association of an intra-abdominal abscess. In this scenario will be the most common cause. So I will repeat my point. So it will be either due to an iatrogenic
bowel injury
or due to an anastomotic dehiscence, may say anastomotic blowout, with or without an intra-abdominal abscess, producing an enterocutaneous fistula. Yes. Take a second pause and then tell to the patient that yes, if this is so, then sir, there can be some rarer causes of enterocutaneous fistula also, which includes a spontaneous enterocutaneous fistula. Now,
case of Crohn's disease.
Very good. Now, doctor, can you tell me what are the causes of a spontaneous enterocutaneous fistula?
Sir, inflammatory bowel disease like Crohn's disease, malignancy, radiation enteritis.
Okay, and in India,
actinomycosis.
Excellent. So, actinomycosis is rare disease, sir. We will always think about tuberculosis. We'll think about inflammatory bowel disease like Crohn's, sometimes malignancy. So I'll again repeat my points. So when the examiner is asking you, why did the fistula form? Say, sir, it is probably based on the etiological type. Okay.
Yes.
So
Yes.
this is the first answer, that is usually the beginning of the day that you are required to say to the examiner. Now, the second question is that how do you classify an intercutaneous fistula based on the output amount?
Yes.
Do you know of any classification?
Yes. Yes, sir.
Yeah,
It
go
could be
on.
the low output fistula, medium
Okay.
output, moderate output fistula, and high output fistula. Low output fistula, if content is less than 200 milliliter per day in 24 hours. Moderate output if 200 to 500 ml in
Okay.
24 hours,
Okay.
and high output if more than 500 milliliter in.
Excellent. Very good. So that means the second classification, so the first classification is based on the amount of the output. More
Yes.
than 500 ml is a high output, less than 200 ml is a low output.
No.
Very good. Now the next one is a little bit now gradually inching up our discussion. What do you know about the types of fistulas that are classified based on the site of the bowel? Have you known about this one, sir?
Site.
Based on the
Sir,
site.
gastric could be gastric fistula, duodenal fistula.
Sir, we know that, sir. It will be then, okay, esophagus, stomach. But when you talk about the classification, doctor, remember
Yes.
that we are talking about these groupings because they have a management importance.
Yes.
So, enterocutaneous
Could be
fistulas.
internal fistula.
No,
Or
no, 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 doctor. Again, kindly do not mistake an internal fistula with an enterocutaneous fistula. This is the reason I started the day with asking you about a fistula. Internal, you may say, we are talking about enterocutaneous fistula.
Yes, that is
So,
external.
skin fistulas, doctor. Okay, right.
Yes.
Talk about this one. So, what are the types of EC fistulas based on the site of the bowel? So please remember there are 4 types. 1, 2, 3, 4. Type 1 is usually in relation with an esophageal and gastric and duodenal. So esophagus, stomach and duodenum fistulas are type 1. Type 2s are small bowel. Type 3s are large bowel. Type 4 are enteroatmospheric, regardless of the origin. So repeat them after me, please. What is type 1?
Yes, sir. Type 1 is esophageal, duodenal, and jejunal.
Na, gastric.
Gastric.
Type
Esophageal,
2 is?
gastric, and duodenal.
Okay. Type 2 is?
Type 2 is small bowel.
Type
Type 3
3 is?
large bowel. And
Very
type 4
good.
is enteroatmospheric.
Excellent. Which is regardless of the etiology. It could be a jejunum which has opened up, but still it is atmospheric. So this is technically, but we will be talking about an enteroatmospheric fistula at the end of the discussion. Right. Now, doctor, what we will do is that, so this is the first is the type of the fistula. Now, the second point to ask about is that, so we can see the dressing being soaked with a fecal fistula, fecal material or a stoma bag called as an wound manager being applied. Now, beyond the fistula that is being draining into that bag, what are the other points in the patient's examination that you have seen?
Yes. I will see the surrounding skin, sir.
You
There
have
could
seen
be
around skin. Okay. Any other better things, sir?
sir, there could be the skin excoriation, erythema.
Okay, doctor, let us start with the first ones. Let us start by talking about the patient overall.
Yes.
Talk about the patient overall. So start from the head to the foot. So what are the things that you have seen in the patient to begin with?
Yes. Sir, sir, generally, first we will take vitals, whether percentage, check blood pressure, whether percentage tachycardia, pulse, mm, mm, then whether patient is pallor. Mm,
Doctor, so let
then
us see, your thoughts needs to be organized and you need to tell to the examiner that, sir, the first of the points about any fistulas to understand are the number one is that, sir, I have taken a history about what are the clinical symptomatologies in the patient, which includes the presence of symptoms like fever, pain, abdomen, pus discharge from the wound. Number two, I have asked the patient about the diet intake. What are the diet that he or she could tolerate? On examination, I have looked into the vitals of the patient, ruled out signs of sepsis because these are important management decisions. So I'll again repeat. You have taken a history, you have looked into the general survey about the signs of
signs of
sepsis.
sepsis.
You are asked about that as a part of your examination. You can be asked about what is the SARS to
Yes.
what is the Q so far. So it depends upon the examiner, but you can be asked about these questions also.
Yes.
Okay. Now followed by what is the nutritional status of the patient? Extremely important because 15 minutes down the line, we are going to discuss extensively on nutrition. So you are required to see the nutritional status of the patient,
Yes.
particularly measure the BMI, see for signs of malnutrition. Then followed by the examination of the abdomen as regards the condition of the skin, the number of the fistula sites that you could identify if you can see the fistula, what is the content, whether it is bile, firm fecal matter, semi-solid fecal matter, liquid fecal matter. So that is something that you need to know. Okay. The next point of concern after that is talk about the devices that the patient has. Devices means it could be a central line, it could be a peripheral line, it could be a urinary catheter. So these are the points to summarize. Okay. So can you summarize all the clinical examination points for me?
Yes. I will first take all the take the vitals. Then I will ask about the nutrition status, which type of nutrition patient is taking and tolerating. Then I will look for the abdominal. Then I will go for abdominal examination. Check all the check the fistula site, whether fistula has only one opening or it has multiple openings. And the type of discharge, whether it is whether it is bilious discharge or feculent discharge. If it is feculent, then it is liquid or solid feculent discharge. I will check all the catheter. Then I will check the catheter site, and like if patient has central line, then I will look. Then I will look whether there is erythema
Oh,
around the central line site.
good.
And I will also check if there is Foley's catheter in situ.
Right, doctor. So, doctor, this is good enough. So now you have understood what are the points to remember. Now, after you have known about what are the points to see, now comes the most and the most important part of these ones. That is, what are the complications of an enterocutaneous fistula? Because we are gradually going to go into the domain of management. So whenever
Yes.
we talk about it, because a ward round scenario, remember that for the last 20 minutes, we have discussed about the approach, we have discussed about the etiology, and now we are going to talk about the complications followed by the management. Okay, doctor, please tell me what are the classic triad of complications of EC fistula?
Malnutrition, sepsis, uh, and tried-
And
electrolyte
electrolyte
imbalance.
abnormalities.
Electrolyte.
Very good. So, for everyone who is listening to this lecture, please remember that we are talking complications and sepsis, malnutrition, and electrolyte abnormalities are the classic triad of a enterocutaneous fistula. What is the most important cause of death?
Sir, sepsis.
Very good. Sepsis, but some publications also say that malnutrition, which leads to sepsis, or both of them could be the cause of the death. Okay. Now, so after this is done, now comes the treatment of the enterocutaneous fistula. Now, whenever we talk about the treatment of enterocutaneous fistula, now the first, just allow me a minute to share my screen, because I think it will be easy for everyone if we can start writing or we can do something with the screen. Just allow me a second, guys.
Yes.
Just allow me a minute, please. Yes. Right. So, can you see my screen?
Yes.
Okay, right enough. I think you can see the screen now. So, the first thing, doctor, to ask you about it is that whenever we talk about an enterocutaneous fistula, what are the basic principles of management?
Sir, first, stabilize the patient, sepsis control, effluent management,
Okay,
nutrition, mm, proper
and
nutrition, uh, and electrolyte.
okay, doctor. So, if you have said that, this is good enough. Now, see, there are two ways to deal about an enterocutaneous fistula in an examination. Time is very limited, and what we'll do is that we'll talk about things very specifically. The conventional approach will be the 4 R's. You see, what are the 4 R's? The first of the R is something called resuscitation. We are going to talk about resuscitation very soon, followed by rest to the bowel. We are not going to talk about every part of the story. The third of this is a radiology, to see what is the anatomy of the bowel that has been disrupted. The fourth is restoration. If you follow the 4 R's, these 4 R's are the most important pivot, and this is technically the timeline which you are required to know for the management of the fistula. Okay, now let us start by one among the other. But before that, you are asked about that what are the because enterocutaneous fistulas, they come with lots of mnemonic. You see, okay, when you talk about enterocutaneous fistula, then there is a mnemonic that is called as SNAP. Okay, what do you know? What is the SNAP protocol?
Yes.
Okay, what is that one, doctor?
S stand for stabilization, skin control, and sepsis control.
Very good.
N for nutrition, A for anatomic delineation,
Okay,
and P for plan for definitive management.
excellent. S is sepsis, N is nutrition and wound, A is anatomy, and P is a definitive procedure. So either you can use SNAP or you can use 4R, depends upon you. But what we'll do is that we'll start with the first one now. So the first one, as you can see, is the R thing. Huh? Okay. Now the first part of the story is R. So I will consider R to be either a recognition that there is a fistula, or there is another R called as resuscitation, right? So if you have talked about R and these, the first ones are, what is the usual electrolyte problems that are landed up in patients with an enterocutaneous fistula? And believe me, ladies and gentlemen, this question has been one among the most important question that people are always going to ask you. That means the examiner is asking you that if you say about the site of the fistula, what is usually the loss that is encountered in that particular site. So let us start by talking about the small bowel as a content, doctor. Okay, so when you talk about the small bowel as a content, or talking about the small bowel as a part of the GI tract, now doctor, tell me, what are the important things if you talk about the ileum as a part of the bowel? Or what we'll do is that we'll make a small table for everyone so that you can look into this. We'll write about the sodium, we'll write about the potassium, we'll write about the chloride, and we'll write about the bicarbonate. And this is a table that every resident has to remember for all examinations. So let us start by the ileum. Doctor,
Yes.
can you tell me what is usually in millimoles per liter the content of the ileum about sodium? Can you quickly tell that to me?
Millimoles.
Sodium is
100 to 140 milliequivalent.
okay. What about the potassium, doctor?
20 to 30.
What about the chloride? And what about the bicarbonate? What about the bicarbonate?
Don't know.
Doctor, this is something that you must know. This is a must know topic for everyone. So please remember this. If it is a duodenum, what is the content? What is the sodium content? 140,
100.
500. It is usually not acid, it is usually acidic. So that means, now when you talk about the bile as an output, what is the output of sodium? So please remember that these are data, that this table is something from Love and Bailey that you must remember. If it is pancreas, then it is again 140, 575, and 115. So this is a table that you must remember, and examiners will love asking you this table because the first part of your management is always centered on what is the loss, and if you have talked about the loss, then how do you manage, or what is the important point that you are going to do to replenish the loss. Okay, so this is the first part of this one. So what you can say to the examiner is that how do you manage the stage 1 of management is, I will go for a resuscitation. So the amount of the resuscitation that you do, that means the amount of water content, the electrolytes that you replenish, has to depend upon what is usually the site of the fistula, and also along with that, what is the electrolyte that is lost and what is the imbalance that is being felt. So this is the first one called as a resuscitation. Now, with the resuscitation, remember, as I've said, the 4 R's. Remember, resuscitation is the first one. But along with the SNAP thing that we have discussed, the second point of interest is how do you manage the sepsis? Any ideas, doctor, on this patient? How do you manage the sepsis?
Yes, sir.
Yeah, go on, please.
Sir, I will first go for ultrasound or CT CT scan for any intra-abdominal collection and the site and the site of collection. Then we will go for ultrasound guided, imaging guided drainage.
The word, doctor, you are perfectly right. The word that they are going to hear about it is that I will like to go for an imaging to look for technically an abscess or an infected collection. After I have dealt about the abscess and the infected collection, my basic idea is to go for something called as a source control. Okay.
Yes.
And the basic principle behind source control is that prevent an abdominal collection. Now, it is at this point that you need to decide on a pathway either by doing a percutaneous drainage, which will mean giving a pigtail, or you can go for a emergency surgery at the initiation of the fistula, which may be a bit controversial given that the patient's general condition may not allow you to re-explore. But emergency surgery, particularly in this patient with a hernia, can mean a bowel exteriorization, which will technically mean that anastomotic site can be brought out as an ileostomy or a stoma. But remember, this is the part that we are talking about sepsis. So I will again recap the points because enterocutaneous fistula is something that you must understand. So number one, what is the first step that we did, doctor? We did for fluid and electrolytes. Please remember. Followed by what is the next thing that we did? We did by something called a source control. Antibiotics are not the only one to deal with sepsis. And this is not a lecture on sepsis, but those of you who will be asked about sepsis, remember, we nowadays follow something called a sepsis 3 guidelines. If you have known about the surviving sepsis protocol, okay, we are not going to ask you, doctor, about this. So surviving sepsis protocols, and we will talk about sepsis 3 guidelines about management of these. So this is the second point about something called a source control. Now, after you have had a sepsis which is very sorry. Now, after sepsis is controlled, now doctor, very quickly, can you tell me in this patient with an enterocutaneous fistula, what are the common markers that you tell that sepsis has been controlled? Can you talk about a clinical marker?
Sir, sir, there will be fever will be there will be no fever, and there will be pulse rate will become normal.
Clinical markers will be heart rate, respiratory rate, temperature. Okay. So technically, if you remember, I told you about the Q-SOFA criteria and definitely the consciousness of the patient. Can you mention some lab parameters that tell you that yes, your sir is asking you this every day? How do you know that the patient is out of sepsis? Very quickly. Number one,
complete blood
WBC
blood
count.
count.
Very good. Any other better markers, doctor?
Differential count. Neutrophil will
WBC
be
counts, TLC, DLC. Any other more specific points?
Sir, ESR.
ESR is not a good one, sir. We go for markers like CRP.
CRP.
Very good. And sometimes even we go for better markers like procalcitonin. Lactate is not a very great marker in these conditions because lactate is not very specific. So these are the markers that tell you that sepsis is more or less controlled. Okay. Now, after we have talked about that sepsis has been controlled, now we'll talk about that whenever we talk about the first phase is done, now talk about the next phase is rest to the bowel. Now, this is now a controversial scenario where we have moved away from rest to the bowel. But the conventional thought that has been taught for everyone is whenever there is an enterocutaneous fistula, you give a bowel rest. Okay. So yes, whenever we talk about bowel rest, okay, can you tell me what is the usual idea about and giving rest to the bowel, or how do you give rest to the bowel?
Sir, Giving rest to the bowel, it will decrease the fistula output, sir.
Okay. How do you rest? How do you give rest to the bowel, doctor?
Sir, we will stop enteral feeding if patient is taking and start total parenteral nutrition.
Very good. So you go for a total parenteral nutrition. Very good. Now, I'll not be asking you about total parenteral nutrition because that is technically another domain that is done. So we go for total parenteral nutrition. What are your targets that you attain by giving a total parenteral nutrition? What are your targets that you attain?
To nutritionally optimize the patient.
Okay. Number one target is the amount of calorie requirement, which is usually calculated by various formulas like an Harris-Benedict equation, etc. Number one. Number two, after we have talked about the amount of calorie requirement, then comes the macro and the micronutrient replacement. Macro, remember, is usually given by carbohydrate and fat. We do not give proteins in the calculation, and conventional teaching is protein sparing effect is done for promoting more on anabolism. As I've said, these are beyond today's discussion. Micronutrient deficiencies, on the other hand, are extremely important because can you tell me some micronutrient which needs to be replaced regularly in these patients to prevent any or to help in the fistula, to help in the patient's recovery?
Yes, sir. Zinc, vitamin.
So it is usually zinc, iron, and selenium are usually the materials that are usually found replaced in patients, and so these patients are usually given these various points which are asked about to do in a TPN. So the basic algorithm that you are required to know is we give rest to the bowel to promote the nutritional replacement and thus to help the patient attain a point about the nutrition which is being taken care of. Now, this is a point, doctor, at which your discussion is now, as you can see, we are gradually going to more difficult terrains. Okay. So whenever we go for the first phase, as I've said, we have started into the TPN. Now the fistula output can be gradually going down. So after we have done with the rest to the bowel, now we can add another R, that is reassess the patient. Whenever we talk about reassessment of the patient, which usually typically takes place from the 7th day onwards, and then thereafter we go downwards, maybe to the later of the phases, and reassessment can be done either by a CT or maybe done by an ultrasound with a clinical estimation, and then we are going to assess very simple things. Now this is one. If the output is less than 1.5 liter per day, doctor, this is an important point. Okay, what is the modification that you can think about starting in this patient? Remember, we have given the patient with an initial attempt at decreasing the output by a TPN. Okay,
Yes.
Right. So can you tell me what is the important thing that you are planning to do then?
So I will add proton pump inhibitor to
Sir,
decrease the output.
these are supportive treatments. Okay,
Yes.
we'll come to that. Let us talk about this first, reassess, and then we'll talk about all the supportive. Starting from PPI to octreotide, we are going to talk about these ones.
Yes.
Okay, but let us talk about these ones first. If the output is less than 1.5 liters per day, you can attempt an enteral nutrition and you
Yes.
can discontinue a TPN. Please remember that. But if the output is greater than 1.5 liter per day, you don't have an option, but you need to continue the TPN. Please remember that TPN has a lot of side effects. TPN is not physiological. Well, again, as I've said, this is not a nutrition class. Enteral nutrition is always preferred than total parenteral nutrition. Just to ask you, doctor, can you name why?
Sir, to maintain the microbial flora, sir.
Microbial flora is point number 2 or 3, maybe number 1. It is more physiological.
Yes.
Number 1. Number 2, as you have said, it maintains the more microbial flora. Anything more? It decreases the sepsis by preventing translocation of bacteria. So these are what the examiner, and number 4 is this is cheaper.
Yes.
So always try to prefer an enteral nutrition rather than a parenteral nutrition. Okay, right. So this is usually the reassessment. Now, by the time of this TPN rest to the bowel, there are a few supportive strategy. Now, the supportive strategy will include number 1. Can you mention some drugs that have been proposed to decrease the output? As you are seeing something, doctor?
Proton pump inhibitor,
Okay.
H2 receptor antagonist.
H2 receptor antagonist. Very good. Any other drugs?
Yes, sir. Anti-motility drugs like loperamide.
Anti-motility drugs like loperamide. Very good. Any other drugs that help in both?
Then somatostatin analog like octreotide.
Octreotides are helpful. Now, out of these, definitely the examiners will love asking you about octreotide, because octreotides have been the most discussed in the story. But believe me, there are no particular evidences that promote that octreotide is something that is really going to be helpful. Okay.
Yes.
Except maybe in patients with a established pancreatic fistula. This is the only one where octreotide has stood the test of the time, and until and unless the patient has an pancreatic fistula, this is the point of this. But if you talk about an enterocutaneous fistulas, there are still today a good amount of conflicting evidences. We don't have a say a grade 1 recommendation of the use of enterocutaneous fistulas in an established TC fistulas, but people say that the output may decrease. But again, this is no contributory effect. So these are the supportive strategies. Okay. Now, after we have thought about the supportive strategies, now we come now to the next part of the story. After the supportive strategies are done, we have talked about that, yes, we are trying to decrease the fistula output. The next of the supportive strategies is skin care.
Yes.
Okay, right. Doctor, so can you tell me what are the skin care problems and how do you plan to do about this?
Sir, there could be the skin exfoliation, sir.
Okay.
Due to the
So how
intestinal
do you prevent the skin problems?
Yes. Yes. Stoma bags, stoma
Very
adhesive
good.
bags. There.
So that means the first point is that is restriction of the contact. Yes. Or restriction of the contact, which can be usually done either by proper effluent collecting bags,
Yes.
effluent collection systems, okay, and
Yes.
like an wound manager
Yes.
are usually done, or there are barriers. Now, in these barriers, like there are multiple pastes, like something called as the diagum, okay, zinc oxide, boric oxide. So these are the things that are usually given for a skin care for the patient. Now, after we have talked about what are the skin care of the patients done, then, so we have talked about now, see, from the beginning, for a quick recap, what did we start with? We started with a resuscitation. We have now gone to the rest of the bowel, which is given by TPN. By this thing, we have also done a supportive strategy, and definitely the psychological well-being emotional support, and those things do come into this picture. Now we are going into the third R of the system, something technically which we will be talking about the A problem. So the anatomy, and then is this part. Okay. So whenever we talk about this anatomy and these parts, again, now let us come to the important point in enterocutaneous fistula is the third scenario. Just allow me a minute. Now, before we talk about these ones on radiology, the most important point at this site is, if you are thinking about doing a radiology, and we are again going to talk about supportive measures now, what is the radiology that you plan to use to assess the length of the intestine?
Yes. I will go for CT fistulogram, sir.
Okay. Or
To-
on the other point, what are the things to look for?
Yes. Sir. And sir,
Number one, you are looking for the length of intestine
length of intestine,
that
site.
distal to the fistula.
Yes.
Number two, as you have very rightly said, the site.
Right.
Anything number three that you would like to look for, doctor?
Fistula's opening, whether it is single or multiple. Length
So
of the
number
fistula
of
tract.
fistula.
Yes.
Okay. Any more points that you would like to look for?
Length of fistula tract.
Length of fistula tract is a very important predictor. We are going to come to that within a minute. Any other points that you are going to look for?
Obstruction, sir, whether distal obstruction is present or not.
Excellent. And evidence of a distal
Distal obstruction.
obstruction and presence of foreign
Collection.
body.
Foreign
Number
body.
presence of an abscess,
Collection.
etc. Okay. And sometimes even number 8, presence of any other abdominal pathologies of
Yes.
interest. Example, an enteric fistulas that may be present, or presence of other maybe pathologies which could be important. So these are the points that we like to look for in radiology. The next question is, what is the radiological tool that you are going to use? Please understand the questions.
Yes.
What to look for is this.
Yes.
What is the radiological tool? Can you tell me what is the radiological tool that you can
Yes.
for?
CT fistulograms.
You have said about a CT fistulogram. Okay.
Last studies.
CT fistulogram is usually the investigation of choice, in which for everyone as an audience, please remember that if this is the fistula, it is usually something that is injected in the fistula, and you are allowing to see how much amount of the CT fistula or the content is going and in what direction is it going. So this is usually the fistulogram. Conventionally, we did something called as a fistulogram, which has a problem about the distal obstruction being only shown, the length, number, site being not very well understood. So in this modern era, we like to go for a fistulogram. MR fistulograms do not have that great importance in an enterocutaneous, because MR fistulogram will become important, particularly remember in presence of pancreatic and biliary fistulas, rather than talk about small bowel fistulas. Okay. Now, after this is done, doctor, the next important point that the examiner will love to ask you is, doctor, what are the points that help after you have done radiology? You are now going to the last phase of the management. What are the points that are favorable to help about a spontaneous healing of the fistula, and what are the points that are not favorable, which do not allow the fistula for a spontaneous healing? Okay.
Yes.
Can you tell me some favorable points?
Yes. First of all, the site of fistula, sir. If it is jejunal, ileal, and proximal duodenal fistula, then it is
Jejunal
welcome.
ileal is good or is it bad?
Favorable, sir. Good, sir.
No, sir, it is not good. If you talk about
Colonic,
ileum,
sir. Sorry, colonic, not alveolar, sir. Alveolar is non-febrile, sir.
right, ileum and jejunum are not exactly very favorable. Okay, please remember that. Whereas if you talk about other sites, they are technically favorable. Okay, next one to begin with. The
Yes.
next one is, what is the etiology of the fistula?
Yes, sir.
Right.
If it is due to post-appendectomy, diverticulitis, and post-operative, then it is favorable, sir.
So appendix fistulas, diverticular fistulas are good, whereas remember that other fistulas, like in relation
IBD,
with
malignancy,
cancer or etc. are bad. So let us complete the favorable ones, and then, because this table is from Sabiston and this is becoming one among the most important things. The next point of this is the length of the fistula. Now,
Yes.
is a
If
larger fistula good
length,
or is a smaller fistula good?
sir, fistula tract more than 2 centimeter is favorable, sir.
Very good. So that means the longer the fistula tract, so whatever we think may be otherwise, the longer the fistula tract is technically said to be a better one rather than a shorter fistula tract. What is the output of fistula tract which is better?
Low
Less
output.
than 200
Less than
ml in 24 hours. The next one is, what about the presence of a distal obstruction?
Yes, sir.
The presence of a distal obstruction is
non-favorable.
no obstruction is good. So this is common sense. Okay. Next point is, what about the status of nutrition? Definitely, people have thought about that, and it is said that a BMI which is greater than 20 may be beneficial for patients, whereas BMI less than 18 is really bad. Apart from this is, you have an absence of sepsis, which is a beneficial thing. Last 2 points which have now become important for your exit examinations is markers like transferrin
and albumin.
Very good. Albumin, doctor, is not a very good marker. Albumin is a surrogate marker of nutrition and the referral to a tertiary care center.
Yes.
Okay. So these are the usual points that we get to know about what are these ones. Now, I'll change the color of the ink so that you can remember this, doctor. What are the points that are not favorable? The points that are not favorable will include site being in the ileum and the jejunum, cancer as an etiology, radiation as an etiology are not good.
IBD.
Now, so next is bowel that is discontinuous. That means this is one part of the bowel and this is the fistula. So this is the proximal bowel and this is the distal bowel. So this is a bad kind of a fistula. Okay. Next is presence of an abscess by the side of fistula. So that is the reason we are draining the abscesses in the beginning is really bad. The next is the output of a fistula greater than 500 ml. The presence of an active sepsis, presence of again an active sepsis, presence of malnutrition with a BMI less than 18 are all proven factors in that. Lastly, as we have talked about transferrin, a transferrin level less than 200 milligram per deciliter is a bad one. So you are required to know about these ones, about what are the important things about the things that do not allow the fistula to heal. Okay. So
Yes.
after we have talked about these, some examiners are very mnemonic friendly. So they are going to ask you at the end of the examination, what is the mnemonic called friends? Because some examiners are so mnemonic friendly examiners. Okay. So can you tell me what is the F in the friend?
Fistula tract.
No, doctor. These are something. F stands for foreign body.
Foreign body.
Okay. What is the R?
Radiation.
R is radiation. What is I?
I input.
Inflammation or infection. What is E? Epithelization. Remember, friends are not friends.
Yes.
N is neoplasm. D is distal obstruction. And S stands for steroid. What is the important point that I said? Again, friends are not friends. These are the factors that prevent a spontaneous healing of the fistula. Okay, so
Yes.
you have read about this. So these are the points that you are asked about in an examination. So you are now coming to the radiology has been done. You have assessed everything, doctor. Now comes the final part of this. So after you have decided that you have done the radiology, what is the decision that you need to take about the bowel restoration?
Yes.
What is the decision? We have around a couple of minutes only with us.
Sir, I
So,
will go for fistula tract excision with the segmental bowel excision with anastomosis and with.
okay, but before bowel restoration as a postgraduate, you should say that, sir, I will talk about this as an enterocutaneous fistula or enteroatmospheric fistula. So today's discussion will restrict ourselves to enterocutaneous. For a postgraduate, you should know about something called as the Jork's classification or the modified Jork's classification of an enteroatmospheric fistula. Okay. Have you heard about anything about the classifications of an enteroatmospheric fistula?
Yes, sir.
Okay. Can you say me what about this is?
Sir, class one, sir, if there is single opening,
Okay.
single fistula's opening,
Okay.
and there is no no uh, underlying underlying abscess, then it is under then it is 1 and 2A. It was 1A. 1B is multiple fistulas opening along with the multiple fistulas opening.
Okay, doctor, I'll be very specific. 1A is technically a clean open abdomen without adherence of bowel with abdominal wall. 1A is technically a clean. 1B is contaminated. 1C contains an enteric leak. Okay, but all of them are without a adhesion. That means these are easy for an operation when you go for a laparotomy. What is 2? 2 is again a clean, contaminated enteric leak, but there is adhesion in this. So that means it becomes hell of a job to remove the bowel. Number 3 is technically a clean but a frozen abdomen. Again, a nightmare, or a contaminated with a frozen abdomen. Number 4 is an established enteroatmospheric fistula. Now, this is something you are asked for your MCQ examinations. An established enterocutaneous enteroatmospheric is a type 4. So, if we are having this discussion, enteroatmospheric fistulas will need an abdominal wall reconstruction to be considered. So, this is usually a very difficult domain which we will not talk about today. So, talking about enterocutaneous fistulas, as we have said, to minimize the gap and to help you in support, you can use, this is a topic that I really love discussing, is something called NPWTs, or something called as a negative pressure suction therapy in the role of these. But remember, NPWTs will only occur when the output is said to be somewhere between 200 to 500. Okay, but the wound healing rates improve. Remember, this is only a supportive therapy. The usual duration of NPWTs is around 2 to 3 weeks. Are the 4 points that you should remember. So these are the new things that have come up in the management of the wound management in a patient with an enterocutaneous fistula. Final ones to end the class today is that what are the, so you have talked about the ways to restore, that is, as you have very rightly said, you need to understand that if the fistula is mature, the patient is ready for an operation. So the patient will be ready for a restoration when sepsis is eliminated
It is only optimized.
and the patient's nutrition status is adequate. Finally, you have ruled out spontaneous fistulas and granulomatous diseases like tuberculosis. To end the class, remember that you were asked about in nutrition, what are the ways, now this is a difficult question, in which in the recent advances, what are the ways of enteral feeding, as you have always rightly said, in a patient with an enterocutaneous fistulas? Because we have moved a long way from TPN now to EN. So can you tell me some ways of enteral feeding?
Sir, through nasogastric tubes, sir, through feeding
Okay.
jejunostomy.
See, I'll make it very simple for you, doctor. If you are thinking about a fistula from, say, the duodenum, okay? So what we can do is that we can place a tube, or say, as you have said, a nasogastric tube maybe, that can be given distal to the fistula. So if it is something in the upper GI tract, we can place an NG tube in the distal to the fistula can be given. Point number 2 is, if it is an intestinal fistula, say for example like this, what we can do is that this same tube that we are using, which is, so this is the fistula output, what we can do is that we can feed this fistula output into the distal part of the bowel. So what we can do is that this feeding called as fistuloclysis. So this is something you are asked about again in an examination. So this is a very cheap technique, particularly which is done. Okay. So this more or less are all the points that we have talked about in this. So what is important is we have to remember, as I have said, either go for the SNAP or go for the 4 R's. Resuscitation, rest to the bowel, radiology, restoration, or sepsis, nutrition, anatomy, and finally the restoration of these ones. So sir, this I think will be an overall watered down discussion for all the points that we have discussed. Anything to ask about in these ones? Anything to ask, doctor? Or you stop the screen sharing now. Any more questions or any queries that are there? I think there is something in the chat box. Okay. We have repeated the 4 R's. Any other queries or questions that are there? Hello?
No, sir, I do, there's nothing else in the chat box, sir.
So for the recent advances, remember that nowadays people are using something called as a fistula stent, which are either made out of a 3D printed material like a protein plug. So again, so these are the things that will come at the end of the discussion. But for a good word round and for a theory question around for 10 marks for your MS or a DNB, if you have understood today's class, we have started with the 4 R's or the SNAP. We have discussed every aspect of the fistula as time would allow us. Definitely, pancreatic fistulas, biliary fistulas are a very different domain. Open abdomen as such is a very different domain. So, but this is overall, if you talk about fistulas at the points, I have given you more or less a treatment algorithm. Particularly remember the pendulum has swung away from TPN now towards feeding the patient by whatever length of the GI tract that could be available. So this is your point that you must remember. Okay. So with this, if there are no other questions, any other things to ask about? I don't think. If someone has asked nutritional supplement, how much? Sir, as I have said, this is not a class on nutrition, but still, because see, I love talking about nutrition. Nutrition is a different domain, sir. The basic point in nutrition is you need to calculate by something called as an Harris-Benedict equation about what is the nutritional requirement of a patient. The basic philosophy is 25 to 30 kilocalorie per kg per day is a basal requirement. Your requirement is this. Whenever you are talking about a patient in sepsis, enterocutaneous fistulas, the requirement is going to get multiplied, maybe by 1.5 times, 1.2 times, and that requirement is going to increase. But definitely, we do not try to give any requirement more than 2000 kilocalories per day, because it produces a lot of refeeding syndrome like complications. As I've said, the total energy is divided from carbohydrates and fat so that you attain a protein sparing effect. I would love to take a class on the biology of nutrition, as these are very, very basic fundamental topics. So that is for another day, another class maybe. Okay, any other questions, please? Okay, if not, thank you then. Thank you very much.
Thank you so much, sir. Thank you, sir.